Everybody, this is Dr. Amir again. This is part 2 of Introduction to Assistive Technology. Part 1, we've talked about what is assistive technology, and we've talked about categories of assistive technology. We've talked about vision and hearing, and we were cut off where we were talking about hearing and relay services. So I encourage you to review those in part 1. Now, part 2, we are going to continue with the categories of assistive technology. We will talk about AAC, alternative augmentative communication. We will talk about speech communication, and also we will talk about learning and cognition assistive technology and assistive technology for daily living and seating, positioning, and mobility. So speech and communication, AAC, and assistive technology that covers AAC. Those are usually products for people with speech disability. Think of expressive aphasias, for example, or inability to talk or produce voice because of structural issues such as problem with their vocal cord or larynx, or cognitive difficulties or brain injuries or such that keeps those individuals from producing speakable content. An example on that is artificial larynx, and this is an example of technology that helps people with after tracheostomy, and it helps them speak and produce sound. This is an example on a gentleman who is using an artificial larynx.
And they can understand you.
Now, by the looks of it, you can see where this gentleman had looks like a patch over the larynx area over here, covering what could have been, I don't know him personally, obviously, I haven't looked into his history, but it looks like he might have had a tracheostomy at one point, and he's using this handheld artificial larynx to produce voice output. And those individuals are usually okay using that. If you encounter one of them and you don't understand, you can ask them gently and nicely to repeat what they are saying, and they're okay with it. And I have seen quite a few in public and communicating without much difficulty. Now, for other ailments or diseases, clients can use static communication boards, and those are boards with visual or written displays, and usually speech language pathology speech therapists are involved in that. Those boards are usually static, made out of cardboards or laminated boards or papers or cardboards, etc., and they usually look like this. This is a display of a board that is static, made out of alphabets, words on the right side, numbers on the very top. For this client, him and his spouse are using it, and you can tell that he doesn't use his hands, but obviously he has ALS, but he's using a laser pointer that is affixed to his glasses. Now, another way to AAC or technology is speech output softwares or devices. Those are devices or softwares that are installed on laptops or computers that produces output for people who are speaking on their behalf, so to speak. So the client will input the information, and then they will hit enter or produce or say, and then it will say whatever this client wants to say. We will see an example here in a minute. And it could be also symbol making software. So softwares that can produce pictures, and those are boards that, like we saw earlier, a board that is made out of cardboards or laminated and static. Now, dynamic displays will be either a low-tech or a high-tech. So dynamic displays are displays that are not static but dynamic. They can be rearranged or programmed to say different things different times, and those could be either buttons or high-tech AACs. So let's take a quick look at the button. So buttons will look like this, and this for example, Little Mac and Big Mac, and they usually record one message. They can be flat or angled, like you can see. They will be able to record one message at a time, and this message will be either yes or no or etc. So those, or you have 4 different messages over here that you can record, and there could be boards like this, Quick Talker Touch, for example. This one carries 4 messages and 3 at the top. This one carries up to 12 or 14. This one is 23. So different types of boards, and those are, like we've seen earlier, those are kind of low-tech devices, medium-tech devices. They need minimum programming, and the buttons obviously are reprogrammable, and they're usually easily accessible to the client. Right hand, left hand, or sometimes they activate them with the knee or their head to convey simple messages. Again, those are not static, they're dynamic, because you can record whatever messages you want on those. Now, other devices are more complex AACs, and this is a different website here, but those are programmable. Again, this is usually have an output. You can see where it has a writing and it has pictures, and it's usually programmable to convey multiple messages. And there could also be more advanced. This board here, for example, has a keyboard, so you can bring up a keyboard and type whatever you want to type. It doesn't have to be symbols or pictures, and the client will hit enter, and then it will produce the voice for the client. The big name in this is Tobii and Dynavox. They used to be different companies, but they're now one. So Tobii and Dynavox, they produce those high-end devices that you can do anything with, and obviously they sell the hardware that comes with them. So the mounting device, the mounting arms over here, you mount it to the table, or you mount it on top of cooler by the beach, or you mount it in the wheelchair. And also, not only that, but they also have apps. So some of those apps are downloadable to different devices, different computers, or handheld iPads, etc. So you could also purchase an app rather than $12,000-$13,000 AAC Dynavox. Now, what is really important is you always have to have a plan B or an alternative device for the client. So clients especially who use high-tech devices, programmable AACs, they have to have a low-tech device in case they lose their AAC, get rained on, it's left behind, the battery died, you send it out for maintenance. The client have to have a backup plan, either an older device or a basic board where they can communicate their needs until their high-tech AAC comes back from repair. Now, learning and cognition is another AT that we use for learning and attention and memory. So take a minute, and organization. Take a minute to think about what diagnosis that you might have seen in the past that might benefit from learning and cognition organization AAC. Usually, those are conditions such as Alzheimer's dementia, for example. One of them. Another one is attention deficit disorder, maybe. Children who are on the spectrum, they might have some cognitive issues or attention issues. People with cognitive disability, for example, they may not be able to recall all the details. Again, we start with low-tech memory aids and diaries, and those are, they take day by day, hour by hour, and we teach the clients to log their activities throughout the day. So they will say, like, Monday 8 o'clock I ate breakfast, Monday 8:30 I went to school, Monday 9 o'clock I took math class. So basically detailed diary. I took my medication on this time. I took a shower on this day. I went to see my sister and visit my brother on this day. So when they're asked about it, it's a good way to refresh. Instead of storing all that information in their memory and putting a burden on them, they usually store it in a book, the daily log or an memory aid. And this could be obviously written, and it could be verbal, or it could be an app. So those are usually a good way to do that. Now, higher end would be something like medication aids, pill dispensers, alarm clock, etc., note-taking systems, and audiobooks. So let's take a quick look at how a pill dispenser looks. Now, this is off of Amazon. Again, I'm not promoting that, but this is what my search yielded. So this is a pill dispenser that dispenses medication for multiple days and most likely multiple medications. And then somebody has to set this up to the client, and it will rotate, and usually it will lock, so the client cannot open it. Think of somebody with early stage dementia, for example. They live at home, they cannot manage their medication. You don't want them to overdose in medication, but at the same time you don't want them to not take their medication. So it's a good way for the caregiver to set it up, and then it will rotate according to the programming. It will dispense the medication for the clients, and then the clients will take it on time. And once they do take it on time, they may be alerted or queued to take it on time, and some of them will have Wi-Fi capabilities where it will send a message to the caregiver that okay, the medication was taken or was not taken or something like that. So just keep that. This is a good option, obviously, for people who need that extra reminder. Down here is some memory aids for dementia, for example, and those are some suggestions on, again, this is pertinent to dementia only, but some of this assistive technology, virtual assistants, automatic calendars, GPS tracking, reminder messages, medication aids, safety aid, etc. Some of this could be applicable to other diagnoses too, so it doesn't have to be dementia. Reminders like this, for example, this is a nice display and either a hardware or an app that will remind them to drink their water, for example. Something like this is an old style phone, wired phone, where instead of dialing numbers, they dial pictures by picture. And obviously the same thing can be done on newer telephones, where you can program instead of their favorite, instead of being only numbers, it could be numbers and pictures. Audiobooks is another way to engage clients who have cognitive issues. Instead of taxing maybe they're unable to read as much or as fast, or they may forget where they are. So audiobooks are a good way to good assistive technology, and it comes in different shapes and forms, and there are apps and even public libraries. Sometimes they will allow you to download audiobooks for free, and some disability options also will allow you to get free audiobooks. Now, seating and positioning is most of therapists are familiar with seating, positioning, and mobility. Whether you work in a hospital, assisted living facility, or you work in a school system, or you work outpatient, most likely you have seen a wheelchair or a cushion or some type of positioning device. And this is really, sometimes it's good, sometimes it's bad, sometimes it's really ugly, unfortunately. But having a background in this will probably help you to refresh your memory and then maybe give you some more resources. So those are products for people who need mobility assistance and positioning. Now, why do we need to position people? Obviously, we position people for postural alignment, for stability, comfort, and pressure relief. So why do we need them to be stable? Because if you're not stable in a wheelchair, you are not going to be able to use your arms correctly. So the saying goes, what you see on the fingertips start at the hips. So if the client is not able to do their fingertips, fine motor coordination, dexterity correctly, that means we really need to start at their hips, which is pelvic and hip area, so we can stabilize their position, and then they will be able to give us good proximal mobility. Proximal stability will give us distal dexterity in a way. So it will give the client a good fine motor coordination. So this is a really big area, and there's a lot of specialties in seating and mobility specialists you can reach out to. So back to the wheelchairs. Wheelchairs can be manual, they can be power wheelchairs, or they can be hybrid. Everybody knows manual wheelchairs. Manual wheelchairs come in different forms, sizes, designs, etc. So over here we have, like, this is, it's not your typical, but it is common enough that this is a reclining back wheelchair. So not only you have to know the wheelchair, obviously, but also we have to know the attachment that goes with it. The armrests, in this case, they are disc cut. They're cut out for a disc. They are detachable. The leg rests here are elevating, and they also swing away. This particular chair here also has head support, and you have cables over here. That means it reclines back and reclining back wheelchair. So you have to know the chair and its parts. This one, instead of reclining back, it's also tilt in space. Some tilt space can be also reclining back, and some can't. This one again is tilt in space because the seat is not parallel to the ground. And this one is a smaller wheel. This one is a smaller wheel too. So the casters in the front and the wheels on the back are small. This one is big wheels, obviously. So this is a patient-propelled or a client-propelled wheelchair. This is what we call caregiver. So the caregivers have to push this. So even the handles are designed differently. Same thing over here. The handles will be more ergonomics for the caregiver. Let's see what else here. So the cushions can be different, obviously, different designs. They could be made out of gel or foam or air, or sometimes combination thereof. The footrests and the foot plates and the casters come in different sizes and shapes. This most likely is 8-inch caster, whereas this is probably 8 inches. It depends on the specification of the chair. So you just have to know what you are ordering, and the best way to do this is really by doing some homework and reading about it, and also just getting your hands dirty, so to speak. This one has a wider front casters, for example, and the forks are bigger. The footrests are not elevating, but they're detachable. This one, as you can see, the arch over here, so this one is a tilt in space, definitely. Higher end, you can tell. Now, power wheelchairs also come in different designs and different shapes and different specifications. This one here on the top right is center. It has 3 wheels on each side. So this is this one is a back wheel drive. This one is a center wheel drive. This one is a front wheel drive. So the bigger the wheels, this is where the motor is attached. So they have a motor and they have batteries, obviously. They have joysticks. And some of those, the base itself can be independent of the seating system. So you can buy a base, and then you can change the seating system. The chair itself, the seat, can be adjusted wider or taller or longer. So this one is a front wheel drive. Those are really good for maneuvering in small spaces. It has a smaller base of support, but it's really good for maneuverability. This one in the top is rear wheel drive, so it's really good for speed. So if the client is going out in public, they live in a assisted living, but they have to go in public, this is a better option for them. This one is in the middle. It takes a bigger base, but it's really good, but it's not very comfortable to sit on, because every time you go over a hump in the road or something, then it gets amplified because you're sitting right on top of the gears, so to speak. This one is elevating. This one is a folding, and you can tell this is much smaller, more portable chair. So in some of them you can remove the battery, fold the chair. I haven't read the specifications on this one, but most likely if it's foldable, that means you can remove the battery and then put the battery in the trunk of the car and fold this and put it next to it. That's why they're portable. Now, underneath wheelchairs, we also have scooters. We have sport wheelchairs, we have standing wheelchairs, we have racing wheelchairs, and each and every one of those is different. So sport wheelchairs depends on the sport. For example, basketball wheelchairs are different than tennis wheelchairs, that are different than other sports. Standing wheelchairs are that they stand up. You have to have good support for the knee and the lower extremities, so the client can stand up. They have to have a good base of support so clients do not tip over. Racing wheelchairs are usually 3-wheeled, and they have pedals are hand pushed, so the client will be using their hands to push the pedals. This is really a cool website. If you look at this is Wheelchair Skills Program. If you look at that, this is an excellent website out of Canada. If you are asked to evaluate your client's wheelchair skills, this is where you need to go to. So if a client is being issued a wheelchair, a manual wheelchair or a powered wheelchair, and you don't know if they're safe using it or not, go to power chair, for example, evaluation. You open up this. Once it opens up, you can see there are 26 in this case different skills that the client have to master for them to be okay using that power wheelchair. And they go all the way from very simple positioning the controller. Can the client get the controller where their hand is, or their hand where the controller is? Are they able to get their head close to the sip and puff? Are they able to use their shoulder for the joy and stick or the head control? So are they able to access the controller? Are they able to turn in place? Are they able to turn while moving backwards? Are they able to get through hinge doors, for example? Are they able to descend and ascend curbs? So the skills go from the very, very basic all the way to very hard. So I really encourage you to look at that. And you score the clients, obviously, pass, fail, partial pass, and fail, partial fail, or not applicable, obviously. And then you do the score. So this is a good way to evaluate clients' safety maneuvering wheelchairs. Not only that, but the website also has multiple videos. If you go on to their YouTube channel, has multiple evaluations. So for example, here they are evaluating a lady who is using a power wheelchair. The sound is very faint, but they go through the clipboard and they do skill by skill. Now, from the looks of it, this client is using a sip and puff, and she's unable to do that task by herself. So the caregiver has to set up the controller. So that was number one task on the test. Let's go see how it goes.
Now, are there other controller features that you
Okay, unfortunately this is not showing us much. Let's see if there's another video. This one is showing the entire assessment process. So this gentleman is using a sip and puff. You can see that. And there is a joystick here. Looks like it. I haven't seen this video, but it looks like there's a joystick here. But you get the idea. If you need a standardized wheelchair mobility evaluation, there is this website, Wheelchair Skills Program. Again, it does show manual wheelchair, it shows the user, and also shows the caregiver. So whatever scenario you want is there. Now, also parts of the wheelchair you have to be familiar with. Again, like the armrests we've showed in the picture earlier, they can be detachable, they can be welded or fixed, they can be removable, they can be swing away armrests, they could be disc cut, they can be full. Leg rests also, they come in all different shapes and forms, detachable, removable, elevating, articulating, etc. Casters are the front wheels. Casters are, they vary, 2-inch diameter, 8-inch diameter, and they are not meant for weight bearing, so the clients don't take weight through them, but they are obviously for maneuvering. They are stabilizing the wheelchair, but the client weight needs to be taken on the back wheels. There's also anti-tippers, which keeps the chair from tipping backwards. in case they have an amputation, for example, and their center of gravity is shifted backwards. Anti-tippers are a must. It makes it harder to go on curbs, but they are a must nevertheless in some cases. Automatic wheel locks are really a cool thing. If you have a client who forgets to lock their wheels, then guess what? There's an automatic wheel locks. Let's see, wait for this to come up. Okay, and automatic wheel locks are just like the name implies. This is an attachment that you add onto a regular wheelchair. It has a hinge over here. You attach it to the frame of the chair, and doesn't show it here, but there's a platform underneath the seat. So the minute the client sits on this platform, it pushes this thing, swings it up, which means that the brake lock will be elevated up and then they can move. The client gets up from the chair, then it automatically locks itself. They don't have a good picture unfortunately here, but this can be installed aftermarket, so you can buy this and install it afterwards, and this comes in different shapes and forms. I've seen it different styles of this, but this is really good for clients who forget to lock their chairs, or they're in a hurry, or cognitive issues like we've said there. Positioning we've spoke about real briefly, but we position clients for alignment, so we align their joints correctly, and this is really important for physiological functions such as breathing, heart, and also bowel and bladder control and movement. Obviously blood pressure too, so you don't need and comfort, so you don't need the client to rotate it to the right or to the left or laterally flex too much. Also for stability, so we can allow function, and for comfort, and last but not least, we position them for pressure relief. Otherwise they'll end up with pressure sores down the road. Positioning evaluation, we usually start at the edge of the mat. We get the client seated if they can. We also evaluate them in supine position. In the seated position, we usually check their trunk control, their trunk stability. Can they sit unsupported? Can they sit without holding with their arms? How much can they reach forward without falling over? Are they flexible? Are they fixed in their trunk rotation to the right, trunk rotation to the left, lateral flexion of the trunk, lateral flexion of the trunk to the left, neck range of motion, knee, hips, ankles range of motion, etc. We do all of this with the client sitting at the edge of the mat. We get him supine, and we sit on. We don't sit, but we check on their pelvic. Definitely don't ever sit on the patient's pelvic, but you test or check on their pelvic. And to see if they have any stability or flexibility or fixed deformities. You probably can tell I am going without a script, so I'm going off of my notes here, without notes, from my memory, and just looking at those headlines. So if I misspeak, you just have to cut me some slack, please. All right. So the rule of thumb in positioning is, if it's fixed, then we accommodate for it. If it's flexible, we correct it. So what does that mean? So if you have a client who has a fixed deformity, then you accommodate for it. So for example, you have a client who comes to you with their laterally flexed to the right by 10 degrees. You cannot fix it because it's already fixed. So what we do, we accommodate for it. We give them a cushion that allows them accommodates for their fixed deformity. If it's flexible, if this client, you can correct him to the left or to the middle, correctly aligned, then we correct that by using 3 points of correction. So you do 3 points of support for that flexible deformity. So for example, this is a client who is leaning obviously to the right. You can tell their spine is curved to the right, their pelvic is oblique too. So we don't put one point of support where the right shoulder is. If we do that, then the left hip is going to scoot sideways to the left more. So I'm going to stabilize this area. I'm also going to stabilize the left hip area. I do that, then they might also still go to the right or to the left, like trunk flexion to the right or to the left, so I need a third point of support over the trunk. So one point of support, a second one here, and a third one over here. Because doing one will not do the job, doing two will not do the job. So we always have at least 3 areas of support. And support means support. It doesn't have to mean we have to put a belt or a harness or anything on the client to restrain them, but it is to support and give them that correct alignment. Direct Supply is a provider of medical equipments, and they really have a good website here. Again, I'm not promoting them, but they have really good selection of cushions you can look at, and they also have a manual that you can download for different types of cushions. I encourage you to download this manual and look at it. It does talk about the contour cushions, for example, the anti-thrust, posterior pelvic, adductors. Yeah, this is an adductor because it sits on the side. It pushes the client into adduction. So we usually name the positioning attachments based on what they do. So this is anti-thrust because it keeps the client from thrusting themselves forward. This is adductor because it keeps them into adduction. So I encourage you to look at this when you have time. But this is a great, way, different types of cushions and different, anti-thrust cushion. What is that used for? What does it do? You have a wedge, you have a linear cushion, etc. This is really good terminology to be familiar with.